Good morning, everyone. My name is Kay Russos Ross. I am a physician in Gainesville, Florida, at the University of Florida, where I work as an OBGYN, psychiatrist, and addiction medicine physician. It's my pleasure to meet with you today to speak about the importance of treating opioid use in pregnancy. So, with that, we will get started. So I think it's important to always share the data and statistics that we have, and we'll be talking about the US as an overview. Then we'll sort of focus in on pregnant women specifically, and then some data in Florida as well. And what I want you to note on this slide is that when we look at overdose deaths in the US over many years, you see that the numbers continue to increase, not only in men, but in women as well, although women do increase, the increase is a little bit smaller. It is actually still on a similar trajectory. The other thing I'd like you to notice is that between 2021 and 2022, it's looking like there might be a little bit leveling off. When we look at what people are overdosing from, we see that the most likely reason is fentanyl, which is that gray bar. Followed by that are psychostimulants such as methamphetamine and then cocaine. And you can see that has really been the case for multiple years now. When we look at death specifically involving opioids themselves, we see a similar trajectory to that very first slide when we were looking at all drugs and overdose. Again, here showing that men are dying more than women, but women are also on an upward trajectory. And again, noting that between 21 and 22, there has been a little bit of a leveling off, and it'll be interesting to see as we get more data if that continues or not. So when we look at opioids together, some historical information I think is useful and helpful. So back in 2010, you see that we had you see that that's where the sort of increase leveled off of the gray line, which is, or the dark gray line, which is oxycodone, your natural and semi-synthetic opioids. And that is when we started calling this an opioid epidemic. That's when we noticed we had an epidemic on our hands, and when we started doing things such as DEA raids on pill mills, such as starting to implement PDMP or drug monitoring programs. And so as we started doing that, the opioid overdose deaths, specifically from prescription, if you will, started leveling off. But look at what happened. As we started tackling that between 2010 and 2012, heroin really started shooting up, which is that lighter gray line, because it was super expensive to get the prescription meds, and heroin was very, very inexpensive. Then what you see is that green line. As people saw that drug users were using heroin, the manufacturers of illicit drugs got busy and started making the synthetic fentanyl. And then that really took off and really overtook heroin. And what you see now with heroin, that is on a pretty steep decline, and really back to the lowest, or towards the lowest in overdose deaths. Another confirmatory or important information for you to note is the number of pills containing fentanyl that have been seized by law enforcement in the United States. And you can see between 2021 and 2023, the numbers have truly skyrocketed. So now let's focus in on pregnant women. And there have been a few good studies. This is a nice overview of 14 states looking at 14 maternal mortality review committees for a 10-year period. And when they looked at mental health deaths, and for this we mean both suicide and overdose deaths, we saw that 100% of those pregnancy-related mental health deaths were determined to be preventable. And that is quite a statement. When we look a little bit further here and we look at mental health conditions and where they lie in relation to the other causes of deaths, Related to pregnancy, we see that the mental health conditions here again from a different study from Maria from 2017 to 2019 showed that the mental health conditions, overdose, and suicide were the leading cause of maternal death, passing hemorrhage, passing heart disease, passing infection, etc. That study showed that 22% of deaths occurred during pregnancy, and this is of all deaths, not just the mental health deaths. About 25% within the first 7 days, but about 53% happened up to a year after pregnancy. And so that's where the majority of the deaths are happening. And again, really noting the primary cause of death being mental health conditions. This is some data from Florida. The most recent we have is based on 2020 data. And what you can see is that blue line showing the upward trajectory of drug-related deaths and showing that they, again, in Florida, are the leading cause of death of pregnant women. So the Maternal Mortality Review Committee of Florida used to be called PAMR, which was Pregnancy Associated Mortality Review. We changed it to MMRC, Maternal Mortality Review Committee, to be in line with the label in the other states as well. But we sent out this urgent message to physicians showing that, again, in the state of Florida, the leading cause of death was drug-related deaths. Also illustrating that more than 30% of women with opioid use disorder had an underlying depressive disorder as well, and really highlighting the importance of prenatal care and screening for opioid use disorder. So with that, let's move on to screening. So screening is recommended to be universal for drug screening. Every single patient, regardless of insurance, regardless of socioeconomic status, regardless of their job, regardless if they're unemployed, homeless, or a judge, everyone should be screened in pregnancy for substance use disorder. When we think about screening and what we do, there's something called SBIRT that I'm sure you are all familiar with that is recommended as a way to really make an impact on maternal and fetal outcomes. And that is screening the patient first, then doing a brief intervention, which is engaging the patient, talking to them about their risky behavior and seeing what their thoughts are, and then referring for treatment. There is no greater time in a woman's life for her to have motivation to improve herself and make a change than when she's pregnant. So what are the instruments that we have to use for screening? The things that are recommended are validated, and the things that are validated that we would recommend that you use are the 4 Ps or the 5 Ps, the NIDA Quick Screen, or the CRAFT screen. The 4 Ps is pretty easy and self-explanatory. Have you ever used drugs during pregnancy? Have you ever used them in the past? Does your partner have a problem? Did one of your parents have a problem? Do any of your peers have a problem? If you get yeses on any of those, you should look in a little bit further. The NIDA Quick Screen is another wonderful screener. This is really done with you, so not self-administered like the 4 Ps or 5 Ps could be. The thing that's great about this is it really asks about all different drugs of abuse, and it really goes into depth about all the different drugs and abuse. It starts with any lifetime use, then goes on to monthly use, daily use, etc. The other thing that I really like about this screen is that it grades, if you will, the patient and gives you a risk score for them. So are they low risk, are they moderate risk, or high risk? And then based on that, it'll give you recommendations of what you should do from that place forward. The CRAFT is meant for young adults, and again, another good screener that can be used. So what about urine drug screen? Unfortunately, it's called a urine drug screen. It should be called a urine drug test, right? Because it's testing the urine, it's not screening the urine. The problem with using this as a screener for yourself is it doesn't really help necessarily. Depending on when the person last used, they may or may not test positive. Depending on what they used and how long whatever they use lasts in their system, it may or may not become positive. It doesn't detect certain things like alcohol. Depending on what urine drug screen you use, it may or may not capture all the different medications that are out there that patients can be using either licitly or illicitly. And then, of course, there are ethical concerns In the state of Florida, we should not be performing a urine drug screen without the patient's permission unless there is an emergency and they're unable to consent. And again, why is it important to screen? As I mentioned earlier, and I really want this to hit home for everyone, there is no greater time for motivation to change in a woman's life than when she's pregnant. Despite anything else, the overwhelming majority of women want to have a healthy baby. They want to do what is right for their baby. And so this is the time that we intervene. Just because we ask once and screen once doesn't mean we're going to catch everybody, right? People don't always tell the truth. And so it takes time for patients to trust us and to know that we do have their best outcomes in mind and that we are there to be on their side and to help them get treatment. So in an ideal world, we wouldn't just screen once. So the American Society of Addiction Medicine, as well as ACOG, American College of OBGYN, have both had published practice guidelines. They've worked together on each of their practice guidelines. And the overwhelming highlights are that women who are pregnant who use opioids should be using agonist medications rather than withdrawal. Withdrawal has been found to be inferior to the medications because of the increased risk of relapse and possible concerns with the fetus. ACOG again recommends universal screening, and it should occur for starts at the first prenatal visit. In a perfect world, you would screen a couple to 3 times during pregnancy as well as the postpartum period. Again, you should use validated screening tools like the 4 to 5 Ps, the NIDA quick screen, and the craft that we mentioned. Patients who have chronic pain should not only be offered opioids, right? That should be higher up on your list. Patients should be offered alternatives such as physical therapy, exercise, behavioral approaches, etc. And again, opioid maintenance treatment is preferred. Before ever prescribing opioids to any woman of childbearing age or any human, quite frankly, we are all required in the state of Florida to utilize your PDMP, your drug monitoring program, to see what prescriptions the patient has out there. And again, if the only drug that they're using is an opioid and they're not using any other illicit drugs, the women should be encouraged to breastfeed because the baby can still get very small portions of that through the breast milk and aid in withdrawal symptoms. Women should be having preferential admission to substance treatment facility when they're pregnant. They should also be referred for psychosocial support. And last but not least, we should make sure that we give women with substance use disorders access to contraception so that they do not have unplanned pregnancies. So let's move on to treatment options. So the goal is to have people with opioid use disorder in opioid-assisted treatment programs, and that is either methadone or buprenorphine. And what we're trying to do in pregnancy is make sure that the dose that they're on is sufficient to prevent withdrawal and to eliminate cravings. Because if they're withdrawing or if they're having cravings, they're more likely to do risk-taking behaviors. And so those risk-taking behaviors include prostituting, IV drug using, buying pills off the street. And so having them in maintenance program drastically reduces this possibility. Additionally, people who are in programs have 30% the mortality rate of those who are not. So again, opioid-assisted treatment is the treatment of choice in pregnancy. It reduces fluctuations in the dosing because it's a long-acting medication, so the babies aren't exposed to peaks and troughs. It reduces their drug-seeking behavior. And again, it reduces harm to baby because they're less likely to prostitute, less likely to IV drug use, or buy things off the street that could be very dangerous and harmful. So what about medically supervised withdrawal? Is there a role for patients to undergo withdrawal? Yes, there is. But that patient has to be immensely motivated. You have to have very close and continuous follow-up with that patient. And you can slowly start decreasing, tapering down the dose. But as she starts getting cravings or withdrawal, you really need to stop and either go up a little bit or stop at that dose until she acclimates before trying to go down again on dose. The reason we don't want abrupt discontinuation is because of the risk of preterm labor, fetal distress, and obviously the high risk of relapse. So the two medications that we mostly use are the methadone and the buprenorphine because they both have a super long half-life. Methadone is a pure mu agonist, and so it only hits the mu receptor. The mu receptor is responsible for euphoria that people get using opioids, analgesia, which is why people use opioids or why they were marketed, and respiratory depression. And so you can imagine that if patients take methadone, but also take higher doses of methadone or add in oxycodone or fentanyl or anything like that, they could absolutely overdose and die from respiratory depression and sedation. Buprenorphine works a little bit differently. It has a long half-life as well, greater than 24 hours. This is a partial mu agonist, but it has a very high affinity. It binds that mu receptor very, very tightly and displaces any other opioids that were on it previously. It also is an antagonist at the kappa receptor. And what does that mean? It results in less risk of overdose because there's less risk of respiratory depression. Additionally, because it binds the receptor so tightly, if a patient were to take an oxycodone with the buprenorphine, they would have no effect from that whatsoever because that oxycodone can't bind that mu receptor because buprenorphine remains on that receptor tightly. There have been multiple studies looking at methadone versus buprenorphine in regards to neonatal abstinence syndrome. And what we see is that babies exposed to buprenorphine required less total dose of morphine for their withdrawal symptoms. They remained in the hospital for a shorter duration, and they required less treatment. We did a study here at UF several years back and found the same thing regarding length of stay in our NICU. So as we conclude our discussion here today, it's important to remember again that the deadliest time for a patient who is pregnant or postpartum is that first year after delivery. You have hormone fluctuations, you have sleep deprivations. People are struggling to stay in recovery because, as I mentioned, although many are motivated to not use in pregnancy, if they don't have that support after delivery, they're likely to relapse and start using again. So when you couple that with the fact that depression, postpartum depression occurs in about 20% of women overall, and in a much higher rate in patients using drugs, including opioids, it's not a surprise that those patients also don't do well. Finally, prior to the last couple of years, we only had coverage for patients with Medicaid, for example, for up to 6 weeks postpartum. And now we have the wonderful ability to care for women up to a year postpartum. And so that allows us to try to keep in touch with them on a medical perspective, but also emphasizes the importance of that wraparound social support. So it's really important to make sure that women after they delivered are offered family planning support and educated on the use of LARCs. It's important, again, for them to receive treatment for their co-occurring psychiatric disorders, and very important for us to have home visitation programs or support for women so that they're better able to care for their for their babies and themselves. So with that, we will stop sharing. Again, it was absolutely my pleasure to meet with you all today, and I hope that this discussion was useful. Thank you so much.